Hello future doctors, welcome to this high-yield revision module. I am so excited to guide you through this today. आज हम डिस्कस करेंगे एक super important topic, antepartum hemorrhage or APH. Whether you're on the wards, in the emergency room, or sitting for your NEET PG or final MBBS exams, the battle between Placenta Previa and Abruptio Placentae is guaranteed to show up. We're going to make your fundas absolutely crystal clear today, so let's dive right in. Here's our quick roadmap. We'll be looking at the basics and the golden rule, pathogenesis, classifications, risk factors, and clinical diagnosis. Focus karo bachcho, we're moving fast.
Section 1. Basics and the Golden Rule.
Mastering these fundamentals is absolutely crucial. It's not just for getting your MCQs right, it literally saves lives in practice. Just picture this, okay? You're the doctor on duty in the ER. A 32-week pregnant female is wheeled in with sudden vaginal bleeding. You have seconds to think. What's your immediate next step? Keep this scenario in mind as we unpack the basics.
First up, we've got to precisely define what we're actually dealing with. Antepartum hemorrhage, or APH, is any bleeding from or into the genital tract beyond the period of viability. The anrakna, in our context, greater than or equal to 28 weeks is the magic number. If the bleeding happens before this, we're usually talking about an abortion or miscarriage. But at or beyond 28 weeks, that is APH.
So who are the major culprits behind this bleeding? Abruptio placenta is your #1 most common cause. Never forget that. Following right behind it as the second most common is placenta previa. Other causes include vasa previa, preterm labor, and uterine rupture. But our main focus for this explainer is the big clash, abruptio versus previa.
Which brings us to the Golden Rule. Read this carefully. In any third trimester APH, a per-vaginal or P/V exam is strictly, absolutely contraindicated until placenta previa is ruled out. Ye high yield point to MCQ Kaylee guys. Never do a blind P/V exam. If that placenta is lying low and you poke it blindly, you're going to cause a catastrophic hemorrhage. Always remember this rule.
Section 2. Pathogenesis. Let's look at the mechanisms.
Concept ko samjho. If you get the mechanics, you won't have to ratta maar or rote learn the differences ever again. Let's look at placenta previa first. Here, the placenta has implanted in the lower uterine segment. As pregnancy progresses, normal uterine contractions or cervical dilation create this shearing force on the awkwardly placed placenta. This mechanical shift simply opens up the venous sinuses and bleeding starts. But notice a very crucial point here. The placenta doesn't actually separate from the uterine wall. Because of that, there's no massive release of thromboplastin.
Now, contrast this brilliantly with Abruptio Placentae. Here, you've got a normally located placenta up in the upper segment, but it separates prematurely. It starts with vessels rupturing in the decidua bassalis. Blood accumulates, forms a clot, and that physically pushes and separates the placenta from the wall. Now, because of this traumatic tissue necrosis, a massive amount of thromboplastin is dumped into the maternal circulation. This is incredibly dangerous and rapidly leads to severe fetal distress.
Section 3. Classifications. Let's talk types and grades.
Examiners absolutely love testing these exact grades. We'll start with the classic, old classification of placenta previa. Just visualize how the placenta sits relative to the internal os. Type 1 is lateral, so just dipping into the lower segment. Type 2 is marginal. It reaches the margin of the internal os, but doesn't quite cover it. Now highlight type 2 posterior in your minds right now. This is the really dangerous variety because the fetal head can actually compress the umbilical cord against the sacral promontory. Then we have type 3, which incompletely covers the os. Building on that, we have type 4 previa, complete or central. The placenta entirely covers the internal os. There's no way a baby is delivering vaginally through that. Now, let's contrast this with the Abruptia placenta types. You can have a revealed variety, where the blood tracks down and escapes out the vagina, or a concealed variety, where a massive retroplacental clot is just hiding behind the placenta with zero visible bleeding. But actually, the most common type is the mixed variety, where you get both the hidden clot and visible bleeding.
Today, we also use a newer classification for previa, which keeps it simple. It just divides it into a low-lying placenta, which is basically the old type 1, and true placenta previa if it reaches the margin or covers the os. For abruptio, we use the Page classification. This grades abruptios strictly by maternal and fetal compromise. Grade 1 is just bleeding but with normal fetal heart sounds. Grade 2 introduces fetal distress. And grade 3, that's a massive disaster. We're talking maternal shock, possible DIC, and fetal death.
Section 4. High-yield risk factors and associations.
You really need to be able to spot these patients the second you read the clinical vignette in your exam. Previa is all about mechanical issues and scarring. The biggest risk is a previous placenta previa. Other risks are a large placenta, like from twins, and adhesions from a previous C-section that prevent normal upward migration. On the flip side, abruptio is all about vascular issues. CDC bathe, hypertension means abruptio. Pregnancy-induced hypertension, cocaine abuse, or a sudden external trauma, these are the classic triggers that just burst those desceral vessels. And because of where the placenta is sitting, placenta previa is famously associated with malpresentations. The bulky placenta in the lower segment basically blocks the fetal head from engaging, pushing the baby into a transverse lie. We call this the Stallworthy sign. Previa is also heavily linked to placenta accreta, especially if there's a prior C-section scar. Abruptio, however, is a systemic nightmare. Thanks to that massive thromboplastin release, it is highly associated with disseminated intravascular coagulation, or DIC, and preterm labor.
Okay, check out this incredibly important visual finding. This is the famous cuvular uterus seen in severe abruptio. The retroplacental bleeding is so intense here that blood literally dissects right into the myometrium, giving the uterus this crazy, bluish, bruised appearance. If you see the words cuvular uterus in a question, it's a classic buzzword screaming abruptio.
Section 5. Clinical presentation and diagnosis.
Now, this is how you're actually going to make the bedside diagnosis on the wards. Hammer this home. Placenta previa presents with bright red, absolutely painless and recurrent bleeding. There's often zero warning. The patient might literally just wake up in a pool of blood. Abruptio placenta presents with dark red, severely painful, continuous bleeding. There's almost always abdominal pain and a history of trauma or high BP. Painless versus painful. That is your biggest clue.
When you palpate the abdomen, the tactile difference is night and day. In previa, the uterus is soft, relaxed. It's non-tender. You can easily feel the fetal parts and hear normal heart sounds. But in abruptio, the uterus is tense, tender, and rigid. It feels rock hard, like a board, because of that hidden retroplacental clot and the extreme contractions. Because it's so tight, fetal parts are super hard to feel and distress is almost always present.
So how do we confirm all this? Remember our golden rule, no blind PV exams? Instead, the absolute investigation of choice for placenta previa is the transvaginal ultrasound, or TVS. A careful TVS lets us measure the exact distance between the external and internal os safely. It's the gold standard. For abruptio, the diagnosis is primarily clinical, but we support it with an ultrasound to hunt for that retroplacental clot.
Well, that brings us to the end of our explainer. But before we wrap up, I want to leave you with a quick, provocative clinical question. If a patient comes in with classic painless bleeding, but you do the ultrasound and see a perfectly normally located placenta, what hidden, dangerous cause of APH must you rule out next? I'll give you a hint. Think about the fetal vessels. Keep pondering that, keep revising these concepts, and I'll catch you in the next revision module. Study hard.